I'd now like to welcome Associate Professor Amy Keir. She is a clinician researcher at the University of Adelaide and SAMRI. Currently, Amy is the South Australian Ambulance Chief Medical Advisor and works clinically as a MedStar, kids consultant and as a neonatologist at the Women's and Children's Hospital. Her interests are in clinical practice improvement and closing the evidence to practice gap in perinatal and paediatric healthcare. Thanks, Amy.
Thank you very much for inviting me along, and thank you for the opportunity to talk to you all about our program here at Women's and Children's. So kind of I'm not talking about global health now I'm talking about a tiny little program in a little hospital in Adelaide, but yeah, it's still hopefully in the same theme. So I'd like to start by acknowledging that I'm on Kaurna land, and that I'd like to acknowledge the traditional owners of country throughout the Adelaide Plains in South Australia, and that I recognise a continuing connection to their land, their spirituality, history and culture. And I would like to recognise the overrepresentation of Aboriginal and Torres Strait Islander babies in the program that I'm about to talk about, and sort of acknowledge a lot of the complexities in that space, and that I'm not an Aboriginal woman. I'm a white woman working in this space, and very grateful for the advice and counsel that I've received, and continue to hope to be very open and continue to evolve our program as we all sort of learn more as we work in this really challenging space. So our Cocoon program that has been funded by the Women's and Children's Hospital Foundation sort of started out probably in about sort of 2020, beginning of 2022. And it came about as a sort of a clinical practice improvement program around the care of high-risk infants. And I think even now thinking about that term of high-risk infants is probably not right. It's a group of infants that have been born into circumstances that are challenging for many reasons. So what is our program? Well, when I was working more in the neonatal unit at Women's and Children's, I started to wonder what happened to some of the babies in our unit that were being discharged home under Department of Child Protection orders. Most of the time they were babies who'd been born at term, were a reasonable size, were feeding okay, and they weren't seen as particularly complicated. They were going into foster care or kinship care. They weren't seen as a very complex neonate, and they were going off. And I started asking, so what happens? It's like, they go see their GP and they get some CAFS nursing visits. So I'm like, okay. And then they made me start to think about sort of how we followed up infants in our unit. And this was sort of a process map that we did a couple of years ago. We're pleased to say that it's much more organised now, more broadly, with the way that we follow up infants that come out of the unit. But what really continued to stick out for me, and why this program came about, was for babies that were being discharged out of the neonatal unit and also out of the postnatal ward under Section 41s or under short-term guardianship orders. What was happening to them? And I followed in my private clinic that was very not private and became a very sort of eclectic clinic. And I'd like to thank the private consulting suite for letting me do all sorts of things in there for a while. We used to run 3 rooms at a time. It was great as a pilot program. And started by following one particular baby who had gone home with her aunt, and I sort of thought, no, come see me, we'll sort out that scan, and I'll see you once or twice, and that'll be pretty straightforward. And it came quite clear with this particular family, this baby and her older sibling were a lot more complicated and really did need more comprehensive, complex, unfortunately, hospital-based follow-up. And then I started to sort of think, maybe I might just see in my clinic, I might just see all of the babies that are discharged out of Women's and Children's under short-term guardianship orders. Because I'm like, there can't be that many, right? And this is where it gets a bit sobering. It's not really clear how many babies are discharged out of our hospital under short-term guardianship orders from their birth admission. It's probably around 25 to 35, maybe 40 a year, and then there's a number of babies that go home on DCP safety plans as well. So again, that's quite sobering to know we don't even really understand. And then also the information gathered about what the proportion of those babies that are Aboriginal or Torres Strait Islanders, also unclear as well, but it is improving in our understanding of how many babies there are. The other thing that sort of made me think as well, I was like, well, we could just see these babies in our neonatal outpatient program, which again has undergone some review and hopefully will be more responsive. But we sort of looked at how many families did not come to neonatal appointments, and it pretty much sat around in 1 in 4 didn't come. And one of my neonatal trainees did a bit more of an audit and looked at a lot of the data. One of the more common reasons were people didn't even know they had an appointment, so that was a bit limiting. And then for families that were often in more complex situations, they may not have known about the appointment, or we did very daft things like they lived in Port Augusta and we said, hey, come and see us. So there were some complexities in that space as well, which hopefully have been addressed. So what we did, and we started a pilot program, because it's always good to start with a pilot, right? Because once you get started, it's hard to say no. But we had a vision, it's very long, but it was to provide a collaborative, multidisciplinary, evidence-informed, coordinated outpatient care to vulnerable infants and their carers. And as I'm going on my learning journey, vulnerable infants is perhaps not the best term anymore. It's infants that, and I haven't quite figured out how best to express it, but they themselves are not necessarily vulnerable, but they may have been a situation that needs more support to help them reach their full potential. So we started a pilot program back in February, March 2022, and I was very ably supported by a number of my allied health colleagues, Kirsty Morgan, Wei-Ren Chong and Emma Evans from our allied health team here. We had a virtual team, so once a fortnight they basically, don't tell their department, donated an hour of their time where we sat together and discussed the babies that I was seeing in the consulting suite here. And we also were fortunate to have Elsa Giordini, who's a perinatal psychiatrist, in that space as well. So although we didn't actually see these families and babies together, we were able to discuss any concerns, who'd seen, and we actually were able to have a bit more, at least, virtual joined up care. So instead of me seeing a baby and then having no idea what speech path or physiotherapy did, we actually all were able to communicate. Over that first year, probably had about 55 babies that came through the pilot program, and of those babies, about a third were Aboriginal babies, and most of those babies were and are in kinship care. And it became really apparent looking at that cohort of babies that very, very few of them were healthy babies who were growing well and were developmentally thriving. They were the minority of babies. They certainly were in there, but that was not the most common baby. And this was really apparent very quickly amongst that cohort of babies. So a cohort of babies that I had thought that were being sent out of our hospital, pretty good size, feeding well, no real issues, that became apparent that they were having quite significant issues across that first year of age. So that's when, fortunately, and it was not easy, we got some funding, and it's a long, convoluted story about how we got there, but I can assure you there were many evenings of me writing different grants, trying to do all sorts of things to get funding for some sort of program, and it sort of ended up with a bit of good fortune, something that was rejected, managed to connect with someone else, and the foundation became interested in our program. And that's where, never give up, people. If you've written something and you think no one will ever fund it, just put it in a drawer somewhere, because someone someday, after you've probably written it 25 times, might actually want to fund it. So we were very fortunate that the Women's and Children's Foundation did fund our program for 3 years, with possibility for an extension. And I like to hope that after a couple of years, no one will want to get rid of us, but we'll see. So the point of our whole program is and because this is from my quality improvement background, is that we really want to be able to provide the majority of babies who have their initial birth or initial neonatal admission here at Women's and Children's, who have active Department of Child Protection case management at that time around their birth, that they all have comprehensive health and developmental assessments and ongoing care plans. So not just a health check, not just a developmental screen, but they're seen by either a sort of general paediatrician or myself, a neonatologist. They're seen by a neurophysiotherapist and do have a developmental screen. We also, and I'll talk about this more, have an infant psychologist who's an infant carer therapist as well, and a social worker in the program. The other part of the, I guess, evolution of the program was it felt, especially as we were starting around the funding and what we were doing, that we knew we had about a third of the babies were Aboriginal. You know, we should have an Aboriginal healthcare worker in our program, and that's like, yeah, we need to, you know, tick that box. But for me, what I really wanted to do was start the program and then see what the needs were, and then work with some of my colleagues in the Aboriginal Health Directorate and also with CAFs as well, to identify who, how and what would be the best way of having an Aboriginal person within our program, rather than sort of saying, oh, this is what it seems, because and you know, maybe that was right or wrong, but I'll talk about that a little bit more. But we looked at a number of reasons why our program might address some of the holes. We certainly found very quickly that with our CAFS colleagues in the enhanced care program, they were really struggling with, they knew that a baby might be developmentally delayed or have feeding problems, growth problems. They would refer them to a GP, and often it was just whichever GP they could find. And if the GP didn't quite think that there was a problem, or definitely thought there was a problem, and then they put them on a waiting list somewhere, and it would be months before they would get seen. And the CAFS enhanced care nurse cohort would get really quite understandably frustrated with that. And what I wanted to do was make sure that our program, any of the CAFS enhanced care nurses through Deb Craig can refer to us directly. You don't need a GP referral, they can just come straight back and see us. There were also really, around these potentially high risk babies, if they were seen in our neonatal outpatient clinic, often we weren't sure who the foster carer or kinship carer was when they went out of the hospital. And then there were troubles with communication with DCP, who was a case manager, and then that would all get lost and too hard, and the baby wouldn't necessarily come back. And you know, having a dedicated program where we know who the DCP caseworker is, we know whether we have the foster carer details or the kinship carer details, and it is revolutionary, but we call them directly. So whilst, and like, to be honest, like traditionally what's happened is the communication comes through DCP. And, you know, what my general thing was, we tell DCP what's going on, but we work with the family or the foster family. Like, we don't, because if you wait for permission, it'll be like 6 months later, right? And these babies don't have 6 months to wait for that. And the other parts of our program, I'll talk a little bit more about some of the specifics, but we've certainly been able, through the program and with a focus on increasing communication, so both with the Department of Child Protection, most importantly I think with the kinship carers and foster carers that are looking after the babies, shockingly, but often they were somewhat left out of the loop about what was going on, and also communication with our CAFS colleagues as well, because you know they go out, they see the babies, they do a wonderful ASQ, they do all the developmental checks, and then what happens after that? Because it is wonderful to think that primary care, like my general practitioner colleagues, could provide this care, but a baby might move a placement, they might move different GPs, it gets really complicated. Like, there's certainly babies in the program that our program has been the consistency across that first year, which is horrifying, but at least someone knows them and knows what any of those complexities are and can make sure that their longer term carers know that as well. I should also acknowledge that the support that we've had sort of within WCH with referrals, so both from the Women's and Children's social work department and also my postnatal high-risk midwifery colleagues about identifying these babies as being fundamental, because there's no other real way to identify them, unfortunately. So at the moment, our program consists of, and this is what we got the funding for, is clinic coordinator. So Sally Tripp is an allied health professional who's a social worker. Kirsty Morgan is a neurophysiotherapist, so she's able to provide a degree of therapy, but primarily she works to do developmental screening. And as much as I'd like to say that I'm really good at identifying any developmental concerns, Kirsty is an absolute gun at that and has been incredibly valuable in that space. And we often will see the families and children together. There's myself, and there's Dr. Malithi Hauser, who's a general paediatrician. So those of you who are worried about a neonatologist seeing like actual children, I am supervised by a general paediatrician. Sarah has just come on board with us as our infant mental health clinician, so really trying to take a proactive approach for the babies. I'm sure no one here in this room would ever think that an infant is a blob and it doesn't matter who they're with for the first 12 months. I mean, the trauma from potentially what's happened antenatally, then to being removed from your mother and your family, to be with another family or not with a family, and then to potentially go from a short-term placement to a long-term placement, or there's reunification, all of these complexities, to have someone there that has that focus on that baby's mental health and to bring that to the forefront is really, I hope, something that will be incredibly meaningful from our program. Because whilst a baby might be thought to be in a physically safe environment, there's so much more than that around safety, and hopefully that will help us. At the moment, and I won't talk about it in too much detail in case I jinx it, been in discussion with some of my senior CAFS colleagues about someone coming into the space as sort of an Aboriginal midwife and nurse within our program, not necessarily so much to provide clinical input, but into as a clinician per se, but to help us around better supporting families with sort of health literacy, continuity of care, and linking up the Aboriginal families or kinship carers in our program with the community supports and programs and referral pathways out from us, and for longer term care as well, and also to provide that incredibly important lens that we must have in this program, and hopefully in a way that will be sustainable and meaningful. So with the program so far, in general, we have been able to provide much earlier and streamlined access to allied health therapy. One of the biggest things is that we're certainly being able to diagnose developmental delays and access NDIS much, much faster. So I think a number of these babies were waiting until they were seen in the out-of-home care clinic setting. So generally in South Australia, a child needs to be on orders longer than 6 months to access the out-of-home care clinic system. Even though I think the idea is that young children shouldn't be on multiple short-term orders, in reality they are, and these babies were just not being seen. So even though they're meant to be having comprehensive health assessments, outside of CAFs, they were often struggling to get access to paediatric specialty care. So we see them early and we pick up things much earlier, and we can get them access to existing therapy services, but we get them in earlier, and we can certainly access NDIS much faster. And I think the improved communication has been much, much better around both between CAFs, between us and the family and kinship carers, GPs, and also potentially with DCP as well. And the feedback that we've had so far has been positive, which is good from the families. I think having a key contact point and like a medical home in some degree has been extraordinarily helpful. And I guess one of the things we struggle with is like, how do we show that this has been good when I think most of the work that we've done has been unmet need? But it's my job to figure out. So far, when I started, it was kind of not quite just me, but it felt like that. And then since we've got our big full team almost up and running, but not quite, we certainly had, at the moment, I think we've got 64 babies across the program, and we've had a number that have been sort of discharged, transferred elsewhere, and we still keep obviously getting more referrals. The majority of babies in the program are in foster care. Quite a number are with family, and some are reunified. And we are able to keep supporting the baby depending on where they transition to. So especially for babies that have moved perhaps back with their parents as well, we still will continue to see them till we make sure that they feel as though they know what's going on and that they know who will continue to follow them up. Clinics once a week on a Monday, and as I mentioned, about a third of the babies are Aboriginal, so that's where that really important other part of our program hopefully we'll see come to fruition. And then just finally, if anyone's interested, we at least see them at 6 weeks, 3 months, 6, 9, 12 months. We can see them more or less. They all get seen by a consultant, paediatrician or neonatologist, and by a very experienced senior physiotherapist, and then our psychologist as well will also be offered. We've also got social work support as well. And, you know, the majority of these babies are not typically developing babies most of the time. Like we see like feeding problems, you know, the flatheads, irritability, global developmental delay, a number of issues which if we can catch them earlier and get therapy, we very much hope it will make a difference. And at the very least, it means, I think, for families, they're feeling like they're accessing those services early and are being heard. And we're not over-servicing the children. There was a little bit of concern that we would be seeing them too often and that these babies didn't need to be seen like this. And even interestingly, a couple of people in the program kind of at the start were like, oh yeah, and then now they're like, oh no. I'm like, yes. So, and that was an interesting space to be in, but it was like, no, we're not. And then we're still at this stage working at how we're going to evaluate our program and show that it is genuinely worthwhile, so we actually get ongoing funding. And how can we continue? And one of the brilliant things about having foundation funding is there's been flexibility in the money and what we do with it, which has been absolutely amazing because we've been able to change the roles, or if we need to add something or take something away, we can, which is, I think, unheard of in health, but shockingly, it seems to be going well. So thank you all very much for having me, and thank you. And if anyone wants to email me, please do.